we know that COVID-19 pandemic is caused by severe acute respiratory syndrome, coronavirus 2, first identified in Wuhan, China in December 2019 and was declared as a pandemic on March 11, 2020. Till now, there has been more than 15 million cases worldwide with more than 600,000 deaths till now.
Next slide.
So there are two common modes of transmission. One is the droplet-mediated transmission, and the second one is contact transmission, mainly by the fomites or the physical touch. So the main symptoms are fever, shortness of breath, cough, fatigue, and peculiar symptom of loss of smell and sometimes loss of taste. Main complications are pneumonia, acute respiratory distress syndrome, cytokine storm syndrome, which we have seen in many patients, and this is one of the causes of death, organ and multi-organ failure leading to death. So real-time reverse transcriptase PCR is the gold standard for the testing. And there are multiple, as Mr. Harian also said, that multiple times the guidelines have changed, but the present guidelines are that patients who are symptomatic, having fever or respiratory distress, healthcare workers who have been exposed to suspected or confirmed COVID cases and become symptomatic, and all the asymptomatic high-risk contacts or the contacts of directly of lab-confirmed cases are to be tested by real-time PCR. But as you know, the test takes around 6 to 8 hours for the results to be, to be available. And as the number of labs are not that huge to amount to the number of the tests being done, so the TAT, which is the turnaround time, is almost 24 to 40 hours, which leads to the delay in the diagnosis and more transmission of infection. So ICMR has recently come out with COVID-19 testing using rapid antigen point of care test, which has ICMR has come with an algorithm wherein they say that if the antigen test is positive, you declare that the patient is true positive. However, if the patient is symptomatic, you need to confirm the disease with the RT-PCR. But if the patient is asymptomatic, you can declare the patient as. So next one. So as Dr. Shruti also said, and what is that we have seen that there are 3 types of patients right now. This is the latest guideline by the ICMR how to treat patients with COVID, with confirmed COVID. So they are divided into 3 categories: the mild, moderate, and severe. Mild is when you have fever or asymptomatic upper respiratory tract infection without dyspnea or hypoxemia. Moderate is when you have lower respiratory tract infection, but not amounting to severe disease. That means the respiratory rate is more than equal to around 24 to 30. But the saturation is SpO2 is less than 94% or room air. Severe disease is when you have, you have a severe LRTI with ARDS, requiring mechanical ventilation, or you have room air saturation of less than 90% with respiratory rate of more than 30. So for the mild disease, there are only the precautions, contact precautions, the fomite precautions. And for patients with multiple comorbidities like age more than 60, diabetes. For patients with moderate disease, you give oxygen therapy, and the most preferred therapy is a non-rebreathing mask because it doesn't allow exhaled air to come out. And so, but if you are using an HFNC or a simple nasal mask, it is recommended to use. And they have seen that they've shown that if the patient is awake comfortably, they can do an awake proning. In patients who tend to be hypoxemic despite oxygen therapy. You do anticoagulation in them. It's a prophylactic anticoagulation. You can try steroids, IV methylprednisolone 0.5 to 1 milligram per kg per day, or dexamethasone 0.1 to 0.2 milligrams per kg for 3 to 5 days. And you do antivirals. So HCQ is the main one, ivermectin now coming. And there are some reports that you can use remdesivir also. But you need to do QT intervals, you need to do liver function tests, then you need to do CRP, D-dimer, ferritin every 48 to 70 hours to look for whether the patient is going into a cytokine storm. And then the therapy change and the patient becomes critically ill. So in the critically ill, obviously you do a mechanical ventilation, but you can start with a CPAP or a BiPAP, but the work of breathing has not to be high. We have seen that early intubation definitely helps people rather than waiting for 24 to 48 hours on non-ventilatory therapies like HFNC or NIVs. Then prone positioning, as Dr. Shruti also said, that prone positioning is important. We have had a good result with prone positioning. Anticoagulation, if your D-dimers are more than 10,000, you give therapeutic dose of 0.5 to 1 milligram per kg per 12 hourly. And steroids here, you can double the dose from the mild disease and continue for 5 to 7 days. You can if the patient, you suspect that the patient has a. So as we all know that this disease is there's not a effective vaccine right now, not an effective treatment right now, and everybody, and as it's an old good saying that prevention is always the cure. So what you have to do is hand hygiene, face mask always in public settings, appropriate level of PPE in hospital settings, social distancing, regular disinfecting of the surfaces, self-isolation and quarantine for suspect cases. They should be disciplined enough to do a self-quarantine or isolation so as to prevent and all these have been put in place to prevent the transmission of infection to others in the society as well as in the healthcare settings. So this is what we are doing. This is our, once we enter the hospital, the first thing we did was that there has to be a definite level of personal protective equipment, which is the PPE. So we formulated level 1 PPE where there's only a 3-layer surgical mask with frequent hand washing. So hand washing is with soap and water if available, otherwise a hand rub with a minimum of 60% alcohol volume by weight, but we here have got more than 65 to 70% alcohol in volume by weight in all the hand rubs, and this is provided to V is for N95, disposable gown, cap, shoe cover. Gloves are only used in patient care areas because if you use them outside, there is chances of transmission of the infection. So we have told all staff that when you are in contact with the patients, wash your hands, go to the patients, attend to them, come out, remove your gloves, wash your hands, and that's how you can't transmit the infection to other patients. And goggles and visors are used while there are aerosol generating procedures. And we took a decision. It was our decision as a clinician, my decision as a clinician would have been to use level 1 PP in all non-clinical areas, but the management and particularly our CEO was very adamant that no, we have to give full protection to all the staff. So all the staff outside COVID facility and the high-risk area, holding areas, is being given level 2 PP. That's it. That is a blanket call for everyone. In the level 3 PP, we have an N95 mask with disposable cap, shoe cover, goggles, and here we wear a COVID suit and visors wherever there are aerosol generating procedures like doing the physiotherapies, intubating the patient, doing the bronchoscopies, endoscopies, and this is used in COVID facility and all high risk. The green zone is probably wherein that the patients are safe. As I'll tell you what's the green zone. So this is looks like a green zone. Orange zone where the patient is indeterminate what to do, and this is the red zone where you can see. So once the patient or the doctor or the staff or anyone enters the hospital, it is definitely that you have to undergo a screening. We have a self-declaration by the employees as well as patients wherein these 6 points are placed, and if any answer to any of these questions is yes, so what will you do is that you send them to the holding areas and they are being screened properly. We know that they are not safe to enter the hospital. Okay, so once this is done and the result is no, so we have a thermal screening just at the entrance wherein you have a thermal screen and it has a temperature. Any temperature, if the patient is febrile, he's not allowed to enter. He's not allowed to enter the hospital from the main entrance. He goes to the red or the orange zone. Now for the OPD, what we have done is that all the OPD patients, because no swab is required, so they are indeterminate cases, so we get them into the orange zone. Okay, but a perfect a thorough clinical screening is done like this. So they are in the level 2. This is the patient wearing a mask and history all is taken. A physical screening is done from them, to be quite sure that yes, they are not probably having COVID, and they can be sent to the OPD room for consultation. So consultation is done by prior appointment. All the staff has to be at level 2 and level 3. Now I'll tell you, level 3 is only for OPDs where aerosol generating procedures. If we are doing some minor OT procedures, outpatient procedures, and if the procedure is more than 30 minutes, we get an X-ray done. If the X-ray is clear, we continue with the procedure. However, if it is suspicious, we get an HRCT done. If it is clear, done level 2 PP. If it is so in the hospital IPD, as I told you, we have got 3 IPD entrances. Green, where there is no suspicion of COVID, that means the swab is negative and the clinical screening is negative. Orange is COVID is indeterminate, swab is not done, but clinical screening is negative. In the IPD, we have got holding areas, wherein the patient comes, we keep them there. If the patient is unstable, high risk, so we keep them on one ward or the one ICU, and if the patient is low risk, so, and depending on the hemodynamic stability or the respiratory stability, we keep them in either in the ward or ICU. And once we are very sure, I'll show the protocols, how resilient our protocols are. Once we are very sure that the patients are not having COVID, very unlikely to have COVID, so then we ship them to non-holding areas. So how do we, anyone, fever more than 38, dry cough for less than 2 weeks, breathlessness, saturation, less than 94 for normal patients, less than 88 for respiratory patients, and chest heaviness. Now, why chest heaviness right now? Because we have seen many patients with acute coronary syndrome presenting as COVID patients presenting as acute coronary syndrome, as few with some strokes. So high risk patients, we have divided patients into high risk and the low risk. High risk patients are CKD on dialysis, heart failure or acute coronary syndrome, structural lung disease, patients undergoing chemotherapy or radiotherapy, and post-transplant patient immunosuppression. So once we keep the medical patients in the high-risk wards, if they are high-risk group, either they are symptomatic or asymptomatic, we do a day 0 swab. If the day 0 swab is negative, do a day 1 HRCT. If it is negative, they are low risk, and send them to low risk floors, and then do a day 3 swab. If it is negative, we send them to non-holding area. This is how stringently we are doing. If the HRCT is suspicious, we keep them in high-risk floor only. Do a day 3 swab. If it is positive, we send them to COVID unit. If it is negative, we send them to non-holding facility, but still for our screening, we do a day 7 swab for them to be sure that they are not having COVID. If they are low risk, symptomatic, if they are for the ICUs, so we ship them, do a day 0 swab. If it is negative, positives, we also send them to COVID unit. If this is negative, we wait, because there are high chances of them turning out to be positive. We do a day 3 swab again. If it is negative, then we do an HRCT chest on day 4. If it is negative, we send them to non-holding floors or ICUs. If it is suspicious, we send them to low-risk floors or low-risk ICUs. Repeat a swab on day 7. So this is a bit, I will give just an update on this. This is for the surgical and gynecological patients. Emergency, we can't do a swab. So we take a swab, but do an immediate HRCT chest, and then wait for the results. And depending on the CT findings and the swab reports, we decide. And as I told you, for the medical patient, we do the same for these surgical patients. And if it's a semi-emergency, what we can do is we do a swab first and then do an HRCT. Here we in the emergency, we don't wait for swabs. We do an HRCT because the patient's life is more important. There are all the guidelines. We just do it on the basis of HRCT only. But in semi-emergency or elective surgery, we do a swab, we do a CT, and then OBS patients, a bit of difficulty, right? Because we are not a COVID hospital, so if we do a day 0 swab, if it is positive, we refer them to COVID hospitals. Though in any emergency we did, and we are very proud to say that we did a COVID, we did a cesarean of a COVID female 1 week back, and the child and the mother are good. Mother has been discharged 2 days back. If it is negative, we do it in normal. We repeat their day 3 swab to be very sure whether they are negative or they are not. So if it is awaited, then we again stop and then see what is to be done. Yeah, for minimally invasive procedures, again, there's a consensus made guidelines and all, and for doing these things. So what we do is now, all the COVID facilities and holding areas have been equipped with negative pressure ventilation. I think we are the only healthcare facility right now which has got all of these areas which have got negative pressure ventilation, because negative pressure ventilation significantly reduces the intra-hospital transmission of infection. All the single rooms to prevent the infection, intra-hospital infection or intra-patient infection in the hospital. And as Mr. Harian said, there's a dedicated lift for COVID patients. We have got, with the wherein there is all cordoning of the area through which the COVID and suspect COVID patients are transported. And once it is done, the whole area is terminally cleaned with 1% sodium hypochlorite spray. and solution. Immediately we upgraded our labs. As you all know that Justlook is very keen on upgradation. We have now an in-house ICMR and NABL accredited lab for real-time RT-PCR testing, and the tests are available in 6 hours, which is helping us to immediately transfer patients in and out. You would be saying, is a war going on in the night to ship the patients in and out of the facilities to get the new patients in and to keep the patients safe. We have started SARS-CoV-2 antigen testing. Also, results are available in 2 hours. We are trying to make policies on whom to be done right now. We have not finalized the policy. And we have started the SARS-CoV-2 IG antibody testing, which is for surveillance purposes. So our practice at the end is wearing of appropriate PP, washing hands as per WHO, 5 movements of hand hygiene and 7 steps of hand wash, changing gloves after every patient contact, washing, maintain social distancing, and frequent and thorough cleaning of all the surfaces. Thank you so much for your patient hearing. It has been a pleasure to talk.